So my name is Danielle Rahajasan, and on behalf of the National Center for Medical Legal Partnerships and our panelists, I wanted to thank you so much for taking time out of your very busy schedules to attend this session. We're very excited to welcome you to today's event about promising training practices to meet the needs of providers and patients. Next slide, please. We also want to acknowledge that this project is supported in full by the Health Resources and Services Administration, or HRSA, and that the contents are those of the authors and do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the US government. Next slide. So in just a moment, I'll turn this presentation over to our panelists. But before that, I have a few small housekeeping things I would like to run through with everyone. Everyone joined in on mute. However, we do strongly encourage you to pose any questions you may have about our topic today in the Q&A function so that panelists can see them and can connect with you. If you would like to activate the captions, please go ahead and select live transcripts and show subtitles. You can usually find this at the bottom of your window next to record and breakout room buttons. Also, today's audio recordings and slides will be made available to everyone by the end of this week. And we will share the link to our website in the chat as well for convenience to where you will find the recordings of today's session. Next slide, please. So before we begin, I wanted to conduct a quick poll to learn a little bit about you, our audience. So if we could launch the poll, and if you could just select the type of organization that you work for. Is it an FQHC? Is it a legal services organization, PCA, HCCN? Is it a hospital system, an academic institution? If you do pick other, please let us know in the chat what that may be, if it's an advocacy organization, for instance, or a branch of government, and so forth. So I'm going to give everyone a couple of seconds to fill out the poll. And also there's a second question if you scroll down about whether you have a medical legal partnership or not. And the answers are starting to come in. I think we can close the poll and share with everyone. So it looks like we have one FQHC. The majority of you are from legal services organizations, as well as academic institutions and other. And looks like the majority of you do have an MLP, and we're happy to hear that some of you are developing an MLP as well. So next slide, please. So as I mentioned earlier, today's session is part 3 of the MLP and Health Centers Toolkit webinar series. Next slide, please. In part 1, we heard from folks at the Kaiser Family Foundation and the Association of Asian Pacific Community Health Organizations, or APCHO, about the data on current and emerging social needs for health center patients and how health centers adjusted services and operations during the public health emergency to meet the evolving needs of their patients. In session 2, we were joined by folks from the National Association of Community Health Centers, or NAC, as well as folks from Health Management Associates, who discussed how to build a screenings, referrals, service delivery workflow specific to NLPs. If you want to listen to the recordings for these past sessions, you can find them in the resources pane of NCLP's website. And I think Catherine just shared those links with you in the chat. Next slide, please. So our objective today are to help participants understand the importance of ongoing training to strengthen partnerships and teams, to discuss models and venues for MLP trainings by different audiences, and also discuss promising training practices so that team members can perform at the top of their licenses. Next slide. We will be joined today by an amazing group of people and training experts, and it is my absolute pleasure to introduce them to you, even though they are familiar faces and I'm sure do not need any kind of introduction. We are joined today by Ellen Lawton, who served as a co-director at NCMLP until 2020 and is now a senior fellow at Health Begins, where her work includes supporting NCMLP on a Kaiser Permanente funded project to address legal-related housing needs of the communities Kaiser Permanente serves. We'll also be joined by Kate Marple, who for nearly a decade directed communications for NCMLP. And today, Kate is the principal consultant at Who Tells the Story, and her mission is to change how nonprofits approach communication retelling. And last but not least, we'll be joined by Noel Reese, who is the program manager for the Washington MLP, which is a long-standing partnership between Seattle Children's Hospital, Odessa Brown Children's Clinic, Harborview Medical Center, and Northwest Justice Project. So I know we're all very excited to hear from our panelists. So without further ado, I'll pass it on to Kate, who will kick us off with a short activity.
Wonderful. Thank you so much, Danielle. And thank you all so much for being here. I want to start us off with a little bit of a warm-up activity to really just get ourselves in the headspace of thinking about training and our different perspectives on sort of what that means. So if you could all open up your chat box, we're gonna use the chat box for some responses. And what I'm gonna do is I'm gonna read a couple of one-sentence prompts. And what I'd like everyone to do is just respond with the first thing that comes to mind. Doesn't need to be complete sentences. It can be a word or a phrase. And then I'll read some of those responses out loud into the room so that we can just sort of see where everybody's headspace is at as we get started today. So the first prompt, when I think of training, I think of fill in the blank. So again, a word or a phrase in the chat box. When I think of training, I think of, I'm seeing learning something new, opportunity, presentations, guidelines, resources, several learnings, process, sharing, webinars, practicing, key to success, takes a lot of time to do it well. And I'm seeing several learnings, educations. I'm also seeing repetition. Wonderful. Thank you, everyone. Second prompt, I learn best when, fill in the blank. I learn best when I interact, I'm interested in the subject, I see and then practice, I'm in groups, I can ask questions, seeing, I can participate, I hear it. I'm just seeing several responses about participation and interest in the topic. Working with others, dynamic trainers, I have a mentor. I get to practice in a safe environment. These are all great. It has practical application. The instructor utilizes my personal learning style, verbal processing. This is great. And I want us to hold on to these things that we're seeing in the chat, because some of these are themes that are going to come up in how we're talking about applying different practices to MLP training. I'm going to read two more prompts for this warm-up. So the next one is, I struggle at trainings, or I struggle with trainings when, fill in the blank. I struggle with trainings when it's not interactive, the moderator is boring, the presenter is reading a script, it's uninteresting, it's not clear how it applies to them, I don't understand the why. Yep, the instructor reads a lot of text off of slides. Yep, the instructor assumes understanding without giving us opportunity for questions. It's complicated and too fast. And I'm seeing several different variations on the subject matter isn't either relevant, it's too much or too little information, it's not practical to what I'm doing. It's not scheduled during a time of day that's ideal for learning. Yeah, that's huge as well, for sure. All right, and the last one, the biggest challenge of a training in a multidisciplinary environment like MLP is. So the biggest challenge of training in a multidisciplinary environment like medical legal partnership is. Well, they're flying in fast. So I'll see if I can go up and catch the earlier ones here. Meeting everyone's needs. Yeah. Language and vocabulary. Not being familiar with all the terms. Creating common language. Use of acronyms. Speaking the same language. Having different resources at our disposal. Bridging gaps. Understanding the rules that others have to work by. The vastness of information. Knowing where you fit in. I'm seeing multiple times variations on different languages and acronyms, different levels of tech knowledge and keeping everyone engaged. So thank you all so much for sharing. Like I said, I think that these are really themes that are going to come up in different points through our webinar today, and we'll be able to call back on some of these. And it's really good to know what you're thinking about and what other people in the room are thinking about. What our goals for today is, I know Danielle walked through the learning objectives, but medical legal partnership training is such a core element of this work. As everybody kind of called out in the chat box, we're coming from different worlds, we're coming from different sectors, and we're merging so much. And so training is this opportunity when we can come together and not just sort of learn that deep dive of sort of what makes a good referral, but really learn about each other, right? And how we're going to be able to make this work successful. And so some of that is understanding these different training styles. And some of it is, what we hope to share today, just some promising practices around how we can take this core element of medical legal partnership and make it as successful and useful as possible in the work that you're doing with health centers. So with that, I'm gonna, this slide that we're on right now, I'm gonna hand it over to Ellen, who's gonna take it away.
Great, thanks, Kate, and hi, everybody. Thanks for the warm-up activity. Always learn something in thinking about all of these prompts. And, this has been a journey for me, learning how to do training as well. I was not taught how to do this in law school, and I learned a lot of what I know actually at the feet of Kate Marple here. So, and when I was a court attorney a million years ago, I was presenting to the court memos full of words, not a one-page PDF with some nice graphic design on it. And that's the culture I come from. Is I'm going to give you all of the exceptions to the rules that apply to the facts of the case that I am presenting. And so I wasn't trained how to be an effective, engaging trainer in law school. I had to learn that, and I learned that in large part by working with trainers across a lot of different sectors, including the health sector. And I'd love I think it was, I'm not sure who it was, Bex, who called out trainers who read bullet points of words that are on a slide in front of you, right? And I have done that, guilty. And I've learned not to do that because as it turns out, I'm a visual learner and I like to look at pictures while I'm listening to words. And so I think acknowledging the both individual preferences around training, but also the cultural preferences within our professions is so important, and being able to start there and watch how do the healthcare team members train each other, right? They're not perfect either, but they have some things we can learn, and they have some things they can learn from us about how to share information. And I would say that one issue that is a theme through medical legal partnership, and I think through thinking about how lawyers are trained versus healthcare providers, is lawyers are trained to think about the exception, right? And on the healthcare side, they're thinking about populations and they're thinking about broader compositions. They're thinking about individual patients as well, but they're also trying to analyze information that's coming to them from groups. And so it does look different, and acknowledging that and understanding that is, I think, a key part of how we can be effective trainers as lawyers in the healthcare setting, and how lawyers, healthcare partners need to engage with their lawyer partners and share what works in their setting. So over to you, Kate.
Great, thanks. And I think, everything that Ellen just said is really one of the reasons that co-creating trainings, so spending that time to really understand each other's learning style is so important, but also co-creating, making sure somebody from both worlds is, part of the construction of trainings, because it's going to help not only with style, but with level of content. That's something that comes up a lot. Like oftentimes we're giving too much information in medical legal partnership training. And we'll talk about that even more depth as we go. Next slide, please. So I always think it's really helpful if we just kind of ground in definitions, or in sort of reimagining the definitions of what we're talking about when we're talking about training. So the 4 things you see on your screen, I think are 4 of the most sort of key components, or things that we should really have in mind when we're thinking about and designing MLP trainings. Some of these are things that you're probably already doing. Some of them may not be how you're thinking about training. But all of these are super important when we're sort of building our training agendas. So the first thing is that, at its core, MLP training is really about relationship building as much as it is about the transfer of knowledge. And so when I think about that, I think about a couple of things. One, it's, we should be training, or we should be interacting with people at sort of every level of the health center, right? So not just that handful of providers we might be looking for a referral from, but also thinking about the health center board, thinking about, people who are at the registration desk, et cetera. Making sure everybody knows what MLP is, that the services is available. And sort of just grounding every training, even if you think people know, sort of recapping that sort of why we're here. So I saw that come up in the chat box, right? So why are we here, and what are we doing here? And then whatever other information you're trying to convey, but always starting from that place of like, hey, we're here. This is why we're here. We're here to serve the same patients you are with this need. And making sure you're touching point and building those relationships at every single level, and maybe not just with the folks that you're expecting a referral from. And I think something we see a lot is that those other audiences can sometimes be ignored for good reasons, right? We're super busy. We're trying to, see patients, see clients, and other things can fall off our radar, but those touch points and that relationship building. And while champions are really important, making sure we have a lot more than one champion, because that's sort of the longevity of our programs rely on that. So that's kind of relationship building. Another core aspect of MLP training is that it's bidirectional. So something we've seen a lot over the years is watching MLPs get stuck in this idea that training goes from lawyers to health center staff, right? That it's about sort of referral procedures and knowing what you need to know about legal issues. And those are really important things, but it also goes the other way, right? It's about this exchange of culture, this exchange of processes, of learning styles. And there are a lot of things that the legal team needs to learn from the health center team too, whether it's clinic operations, whether it's things that the patients face, or whether it's strategies about how best to convey legal information to patients. And so really thinking when you're building out your training portfolio, whatever that looks like, to make sure you have information that's flowing both directions, that you have trainings that are designed to achieve all of those sort of goals. This next one is one of my favorites to talk about, which is the idea that trainings are both formal and informal. So sometimes when we're thinking about trainings, we can get very sort of tunneled into this idea that we have to have a longer carved out time, right? Like we have the benefit of today, 30 minutes, 60 minutes, 90 minutes to pull up a slide deck, or it's like a standalone MLP training, right? Where we've invited people just to come for this long period of time to talk just about MLP. And those are trainings, and those can be really useful trainings. And a little bit later, Ellen's going to talk about a lot of the different settings where trainings happen and break these down a little bit more. But it's important to remember that sort of anytime we have the opportunity to interact between our teams from the legal side and the health center side, it's a training environment, right? We're exchanging information, we're learning from each other. So a 30-minute presentation is a training, but so is that 5-minute case consult where someone brings something that's going on in the clinic and you're kind of walking them through, this is the issue, and like, this is what you might do in this situation, or yeah, that's a good referral. That's a training. And I think we need to open up, our idea of what that training is, so that, we are taking advantage of all those little moments and not just waiting for that time where we can get 90 minutes on everyone's calendar, because those are few and far between. And really folding ourselves into the rhythm of where people are already being trained. And, I saw it in the chat box. I don't do well at trainings when it's at a time of day that doesn't work for me. It's the same with, like, if somebody's distracted with something else, that's not a good learning moment, right? So meeting people where they are in places to absorb the information you want to share is a huge part of this. And then lastly, trainings are ongoing. So I know one of the questions we got leading up to today's webinar is like, how often should we be training? What's the frequency or the cadence of training? I don't think we have a set answer that you should be doing it, once a week, twice a week, once a month. I don't think it's about a very specific number, but it should be an activity that is on your agenda every time you're meeting. It should be something that you're doing in an ongoing basis. So I do think, as we expand this definition to be training is all of these different things, not just 90-minute trainings, it should be sort of a weekly activity. When you think about it in the context of who have I talked to this week, who have I introduced the MLP program to this week, whether it's a conversation, whether it's a moment with board members, et cetera. So really, like, it should be a very frequent thing, and it's not one and done. So once you've done a training, you're going to have to do it again, the same one, because staff leave, because learnings need to be reinforced. I saw that in the chat box. I can't just have it once. I got to hear it. I got to hear that common theme over and over again. And these trainings that we do, they're building blocks. They're not endpoints. So they are part of the language of MLP work that we will do in perpetuity forever and ever. Next slide, please. If we're able to go to the next slide, I think Ellen, perfect, thank you. I'm going to hand it over to Ellen to talk about training scenarios.
Great, thanks so much, Kate. I also wanted to acknowledge up top gratitude to Danielle and Catherine and Reha and the team for welcoming us to do this, appreciating NCMLP and the audience here. I'll probably be speaking more to my legal side, given the preponderance of lawyers here, but really welcoming everybody. Also, I saw there was a raised hand, and so consistent with best practices, wanted to acknowledge that, and it's totally fine to pause for a question. Maybe that'll keep everyone engaged. So I think, can you unmute and ask the question? Is that our practice here, Catherine? Oh, it was an accident. No worries, Nola. Happy to hear a question though, folks, if you want to jump in. But otherwise, I'm going to keep going. And I'm going to just talk a little bit about training venues and scenarios. And these are all taken from National Center resources and toolkits, and you can reference them, and I'm sure they'll pop them in the chat. But the overarching theme here is meeting people where they are at, as you can see, as Kate has referenced, right? Everything from curbside consults all the way to standalone learning sessions on MLP. And I think for my lawyer friends, right, one thing to think about is, is this a CLE that we're attending, or is this a hallway conversation that we're having? To Kate's point, because CLE demands, maybe that you're present in. That's continuing legal education, just doing an acronym check, right? And it could be CEUs or CMEs, right? Those are pretty technical and specific trainings that get offered. And very few of those are being deployed in medical legal partnerships. And in general, what you're going to see and what we're developing in the Kaiser Permanente initiative are really about finding where people gather and then deploying brief. And when I say brief, we're talking 15-minute trainings for a group of navigators or a group of community health workers or a group of social workers or physicians or nurses, right? 15 minutes on reasonable accommodation, right? 15 minutes on healthy housing. And so really understanding, where are these venues? Are they virtual? Are they existing team meetings where people are meeting every single week and they invited you in for 5 minutes? That's a pretty sacred 5 minutes as a lawyer. How are you going to spend that time? And you may want to spend that time, to Kate's point, asking a question, right? You can say, what is the biggest problem that you see your patients having in the social determinants realm, right? That's maybe a place where you get information about how to do a better training. And, you know, to think about, like, how can I share information? Do I actually need a slide deck? Will they only listen to me if I have a slide deck? Or can you have a conversation instead and ask questions? I think that all of those things are things that you should be thinking about every time you step into a clinical setting as a lawyer. And then making sure, I think, particularly for those MLPs that are just getting started, I know that there are legal aid agencies around the country that have found it super engaging to invite the MLP champion, the clinical leadership, right? The pediatrician or the primary care physician or the nurse practitioner or community health worker, invite them to your monthly all staff meeting so they can talk about their view of the world and the work they do. And that has had a ripple effect for a lot of legal aid agencies where their peers better understand the value of their work. They understand how to support medical legal partnership work on the legal aid side, right? It isn't this kind of mystery thing that happens over at the hospital down the street, but actually implicates their their patient clients, right? It implicates the people that they're working with all the time. So again, seeing any opportunities to do this work together, to do it in teams, and to have conversations rather than the sheer delivery of, you know, bullet points and rules and sort of laws, right? So I think with that, unless there are questions that are popping up, I'll hand it over to, I think we're going over to hear from an expert now. Great. So Noelle Rees is going to share, I think, some really important insights, having helped to transform how the Washington MLP is delivering trainings. And we're going to get to hear from her about how that came about and some of her insights. Noelle?
Thank you so much, Ellen. And I do want to just express my appreciation for the invitation to share our experience at Washington MLP out in Seattle with all of you today. And I think part of this is just that we have learned as you're just always, it's an ongoing conversation. It's about a relationship, and it's being willing to flex and adapt to what the environment around you is telling you. And so that's really what I want to talk about today is, during the beginning of the pandemic, if we kind of take ourselves back to around March of 2020, how we delivered our trainings had to make some adjustments to that model, because only very essential individuals were allowed into the hospitals, even for our pediatric hospital. as far as parents or caregivers, that was restricted, et cetera. So as an organization delivering trainings, we had to as well adjust how we did that. So let me just spend a minute giving you context for MLP. So the Washington Medical Legal Partnership has been around for about 15 years. Our medical partners are our Level 1 Trauma and Burn Center in Seattle, which is Harborview Medical Center, as well as Seattle Children's Hospital, which is our Pediatric and Adolescent Medical Center. And Odessa Brown Children's Clinic is a primary care clinic, which actually operates a lot like an FQHC. It has mental health, behavioral health, physical health, oral health, et cetera. But it is part of Seattle Children's. And then our legal partner is Northwest Justice Project, which is the largest civil legal aid organization in the state. And then we do use some pro bono attorneys. So that's kind of who MLP is in a nutshell. Next slide, please. Thank you. So this is a slide that just gives you a snapshot, and my apologies, that should have said patient families in 2021, but this is 2021 data. I forgot to update that number. So I think this middle part here, 593 healthcare staff received education through 44 trainings, is really key to what we're talking about today. So if we think about how our MLP is structured, the bulk of what we do is really provider trainings and consultations. We help those on the front lines in our hospital and in our clinics issue spot and identify what might be a good referral for MLP or where MLP can provide resources. So yes, we do direct legal assistance, which is at the top there. About 100 families received direct legal assistance last year. But the bulk of what we do is in trainings and also in consultations. We do a lot of consultations. So that's a little bit about kind of the model. Next slide, please. So again, let's go back to spring of 2020. Oh my goodness, COVID hit, and we had to completely revamp how we were going to ensure that all of those staff, whether it be a provider, a case manager, a family advocate, a cultural navigator, a social worker, any of those folks, community health worker working with our patients, how they got information that was, as we all know, changing, very, very rapidly. And what we really heard and how our lunch and learns came about, that we provided for about 13 months during the pandemic, was what we heard is, yes, people are coming to their clinical appointments as they can, but they're really there talking about basic needs. They are like, yes, we're still having this cough, but we're not sure if we can make rent. And we are really concerned about our kid falling behind in school because of their access to the internet when school went to online learning and so forth. And so we heard from our advisory board of community stakeholders that, we really needed to figure out a way to get front level staff just in time information to be really, really responsive to what our clinicians were hearing, and to really address the needs. And so lo and behold, our lunch and learns were born. And our lunch and learns, we did 28 of these on a biweekly cadence. They were for medical providers on all sorts of emerging COVID-related issues, which, as you all may remember, were literally, 1 month, the housing eviction moratorium status was X, and the next month, there were changes to that. So these occurred every 2 weeks. They were, as Ellen was just talking about, sometimes short and brief is really going to hit the mark. And so we did these over the lunch hours so providers could access them without interrupting patient care. We also recorded them so people could access them later. And we also developed a bulletin afterwards so people could have the resources. But we intentionally structured these. So it was 15 minutes of talking about education rights during COVID, for example, and then 15 minutes of Q&A. And we definitely invited any of the folks attending to ask us questions on the subject of that lunch and learn or on anything else, because they had an attorney from our MLP available to them, and they could use that time, to ask something about pandemic unemployment if that was an issue for their family. So we, going back to the slides that we looked at earlier, we really did want to make that bi-directional. It really was all about the relationship. It wasn't us necessarily just talking to the providers that we had, but what are you hearing from patients? How can this be most helpful? And then another thing that we did that I think was really helpful was after doing these lunch and learns for about 3 months, we did a survey of staff attending to say, okay, are we hitting the mark with this? What do we need to do to adjust this? And we actually got a fairly good response rate, which was for surveys, if you get a response rate around 35%, you should be happy. So we were quite happy with that. And that gave us some really good information. And so we made some adjustments based on that feedback. And an example of that was we heard from some social work staff that it would be great to have the slides ahead of time. And so we're like, okay, let's make that adjustment. And I mean, certainly we were getting flyers out, we were sending out email blasts, we were sending out the link, and we were following it up with the resource bulletin and sharing the recording. But that was really good information. So we had to adjust our process within MLP. Okay, 2 days beforehand, that's what we figured out was the magic sweet spot, where it would be on people's radar because they could see it on their calendar, but it wasn't so far out that it wasn't connecting with them, that it was an upcoming appointment on their calendar. So I just think kind of that ability to keep the conversation going, make adjustments as needed, check back in to see if it's meeting the need, and then continue to do that, PDSA cycle, the plan, do, study, and act, and be very open to adjusting to meet the needs of patient clients. Okay, next slide, please. So this is just an example for you of kind of a save the date email that we would send out. So it tried to just convey the essential information. Again, thinking, providers are going to be really, really busy, especially during the pandemic. So what's the format? Letting them know that they'll have a presentation, that the sessions would be recorded, that they'll receive a summary newsletter, what's going to be discussed, just some quick bullets, and then let folks know that there'll be time for questions. And we always included on these email blasts, this is a pilot project. Please do email us with feedback and suggestions, because again, it's that relationship building. It's that bi-directional. We are not here telling you what you need to know. This is being responsive to what you're telling us you're hearing from patient families. So, okay, sometimes we would scrap our planned lunch and learn, like, wait, that one we're going to put off because we're really hearing that kids not getting their IEPs and 504 plans met with online schooling is a bigger issue. So we're gonna change the order and make that one our next lunch and learn. So I think I want to stop there because I want to respect the time that we have. So I think thank you so much for letting me share, and really. We'll send it back to, I'm sorry, whoever I'm supposed to send it back to. I don't know if that's Ellen or Kate.
I think it's me. Thank you so much, Noelle. And just so everyone knows, we have like one more slide here, and then we're going to move to the Q&A section. So I'm sure you have questions for Noelle. I'm seeing questions come up in the Q&A already, which is great. So if you want to get a question into the queue, please go ahead and open that Q&A tab at the bottom of your screen and toss any questions that you have in there. And we are going to get to those in just a moment. We're leaving a lot of time for questions because we know that's probably the most important part of our time together today, to be able to answer some of the things that you're really specifically engaging with in your own work. So before we move on to the Q&A, I just wanted to offer up almost a mini training format that I have seen, I've worked with people in the MLP world to use and adopt, and it's built off a format that I sort of use in any setting, whether we're talking about medical legal partnership or literally any field. When we're trying to just kind of get to we have like maybe 15 minutes to talk to someone or talk to a group. And we're trying to get to sort of that right amount of information to that group. So here's how it looks when I think about a 15-minute training in the MLP world, when we're really trying to get it to help somebody or help health center staff understand a specific legal issue and how to refer patients for help. So I think of this as like a 3-slide deck maximum if you're using slides, very graphic in terms of pictures, designs, and not text heavy. And I think of there being 3 beats, right? So if this is helpful as you're thinking about crafting a training, it's just one way to think about doing this. So 3 beats. First, you want to engage. And that is to, on whatever the topic is, help health center staff understand why this topic matters right now and to them, right? So hopefully this is a topic that they have already flagged for you. So hopefully this training is in response to something they've asked for. I saw that in, Noelle's slides, like things that they were really asking for, bringing the sort of the answers to the health center staff's questions. So when I think about engaging, there are 3 things that really help someone's brain light up and like lean into something, right? So one is to share a fact about why something's urgent. So not why it's always important, but why it's important in this community today. So if you're thinking about like housing evictions, it might have been, 2 months ago, it might have been the COVID moratoriums are lifting. We're about to see a huge increase in people getting eviction notices, right? It's an urgency right now. So here's what we have to be on the lookout for. So you might start by sharing a bold fact about whatever that topic is. The other way is to tell a story, right? Tell a story about something you've seen in the clinic. Tell a story about a success. Better yet, if this is a legal training, have a health center person tell a story about their great experience on this topic, right? Messenger matters. It matters a lot. So there's no better thing than to hear from someone like me. So in the training, if it's for, let's say, physicians who are making referrals, have a physician, almost testify to this topic and what worked, right? So we can share a bold fact, we can tell a story, or we can start with a question, right? Get people participating before you do anything else. Get their input before you do anything else. Ask a question that will get them thinking about how the thing you want to talk about relates specifically to their job and every day for them. So engagement isn't about telling somebody, we're here to talk about reasonable accommodations, and this is what reasonable accommodations is, and this is why I care about it. It's about thinking, why does this doctor care about it? Why does this case manager care about it? What are they seeing? Why are they going to need to know this information? And then take that and put in a fact, a story, or a question that's going to get them to say, oh, I need this information. I saw this in the chat box several times. Why does it matter to me? Don't wait to say that at the end of the training. That's the first thing you say. If you connect somebody to their why, they'll listen to what and how. If you start with what and how, you'll not, people will disconnect before you ever get to this. Simon Sinek wrote a whole book about this, about starting with the why. There's a lot of research to support this. So you engage them, get them to lean in, right? Using one of those strategies. Then the last 2 beats, I like to think about, again, putting this in healthcare, more healthcare terms. Give them 3 things that will help them diagnose, and then what the treatment is. So when I say 3 things to diagnose, what are the 3 things that this group of providers or this staff or this group of case managers need to know that will help them recognize when this is happening in patients? So I always like to quote the National Center's former medical director, Dr. Megan Sandel, because she always used to say, I'm a pediatrician. And as a pediatrician, I don't need to know all the different types of heart murmurs. I need to be able to listen to that heart and know that something's off and that I need to send them to a cardiologist. That's what I need with the MLP. I don't need to know the history and changes of every reasonable accommodation law. In fact, I won't ever remember it. I need as much information as you think I need to be able to look at a patient and say, ooh, there's legal help for this. Let me get them in front of the lawyer. And so as for the attorneys on the webinar, that's the level you're trying to reach, right? Not giving them the 30 slides history of the law, but what are the 3 things they need to know? So if we were talking about reasonable accommodations, right, which is this idea that everybody has the right to enjoy their housing fully, right, no matter what disabilities they may have, and there are laws to enforce that. So if we're thinking about 3 things, it might be as simple as reasonable accommodations apply to apparent and non-apparent disabilities. So things we can see and things we can't see, right? Might talk about the difference of enforcing that if someone lives in public versus private housing. And then you might say there has to be a medical letter in order to enforce this. So we might be reaching out for those. And this is what goes in a medical letter, right? That's it. Those 3 things might be the only 3 things you share. And then treatment. And so the cadence for treatment, I always think of at what point do they come see you for a case consult? And at what point do they refer a patient? So I actually encourage people to put it into if then like sort of formats. If you see a patient with X, then refer them. If fill in the blank happens, come see us for a case consult and we'll talk through it. And so this sort of format can hit 15 minutes pretty easily. So we kind of engage, we help the health center staff diagnose, and then we give them the 1 or 2 beats for how to quote unquote treat this by connecting them with the legal team and a reminder of how to do that, right? Because maybe not everybody has that referral procedure sort of front of mind. So with that, I think we're going to go to the next slide, which just acknowledges that we're in the sort of Q&A section of this. I know that we've already had some come through the Q&A. And I'm going to turn it over to Ellen to sort of moderate this section and continue to put your questions in that Q&A function.
Great, thanks, Kate, and thanks, Nola, for kicking us off and I've dropped it in the chat with a great question that I'm going to kick to each of our panelists, actually, and I'll just read it out loud here too. So those of you who aren't up in the chat. Which is how, if at all, did staffing issues or staff capacity affect your ability to host trainings? I'm working in a perinatal context in a relatively rural service area, and everyone is stretched very thin because the department is so understaffed. It will be challenging to get in front of a lot of people at once. I love every single aspect of this question, Nola. This is like, I think it's a final exam question on for MLP, right? And so first I'm going to invite in Noelle because I think you are directing your question to her. And then if Kate wants to respond, and then I have a response too. And hopefully that maybe will provoke some folks out there to ask some additional questions. Also just want to call out that Nicole had asked about the slides being emailed after the presentation, and the answer is yes, you will have access to the slides, I think. I'm pretty sure. Yes. So Noelle, you want to comment?
Sure, and just want to reiterate again, that's a really great question. So, how did staffing issues affect our capacity to host trainings? It affected it in all areas, right? So it affected it as far as providers were busier than they'd ever been. So even though they needed this just-in-time information, that's where we had to really think, okay, we have to approach this in a multifactorial way, so to speak. So yes, we can offer it over lunch hour or there's never been a lunch hour in like 30 years, so it's never an hour. But anyways, we can offer it over the lunch time. We can record it. We can do a written summary. So being flexible about, one size doesn't fit all. So that was really important. Another thing was that we had, to be very honest, in addition to the providers being busier than they ever were and patients having just really basic needs that they were concerned about, we also had staff who were trying to do their work, but also had kids at home that they were trying to supervise getting online to do school, right? So then that helped me think, okay, how can I make this lift for our attorneys in developing the slides as simple as possible? What can I do to kind of take any of that off of them, to have a template for them, to monitor the Q&A part myself rather than maybe another attorney monitoring that. So it was just, I think, yes, it definitely made it can make it very difficult when there's not the full resources and everyone is super busy. But I think that's where you kind of go back to let's think and work smarter about this, not harder about this. So what can we streamline? What can we make uniform? And then I think the other part is that loop back, like getting feedback. I would follow up with our social workers who attended a lot of our lunch and learns, even outside of that one kind of evaluation, to say, what do we need to flex here? So I think, again, kind of that open communication, and then doing trainings in a multitude of ways, and having it accessible in multiple ways. I think those were kind of some of the takeaways and lessons learned for us.
Thanks so much, Noelle. And I'll kick it to Kate in a second, but just a couple of my reflections on this really great question. And that this has reverberated through the Kaiser Permanente initiative, as well as really all of the work that's happened, particularly over the past couple of years. Certainly heard it from the field over and over again. And I would just say, and I think, Noelle, your experience is such a good example of this, is don't be overly protective of other people's time as well. Ask those questions, because you may have the impression that they don't have time or bandwidth, and that may be true, but maybe they don't have time or bandwidth for the kind of training that they think they're going to get, as opposed to the short hits that you can provide if you're really being thoughtful about how you deliver the information. And so don't automatically assume that that's not information that people want. They just may want it in a different kind of environment. And so to your last comment, Nola, it'll be challenging to get in front of a lot of people at once. I would say, then don't try that, right? To Kate's has articulated, why it may not be necessary or feasible or even desirable, right? Is that you're actually trying to think about training 2 or 3 people. And maybe that allows you to hone your training, right? And get a better understanding of what they need and get some inputs about how to adjust your training, right? And how to make it so that it is more effective. Maybe it's shorter, maybe it's more targeted, maybe it's, going to shift and be more complicated over time, rather than try to download all the information that you think they might need. So that would be number 1. Number 2, kind of connected to the don't be protective of people's time when they actually may want the information, is also don't assume, and I have done this and continue to do this in my journey in learning and advising MLPs, is sometimes I think, oh, that's way too complicated for that clinical team. Lawyer, you need to dial it back. But you know what? Some of the information may actually land with some of the clinical team members. And so again, to Kate's point, start with questions and asking people and gauging their knowledge about this particular topic. You know, in Maryland cohort that we're working with, they have actually 2 case managers who used to work for housing agencies, right? So they're actually really savvy about housing, and we wouldn't have known that if we hadn't asked, you know, what's your experience here? So that's just another thought. Kate, anything you want to share on Nola's question?
Yeah, just 2 thoughts real quick on this. One, you know, kind of building on what Ellen said, my instinct to that is like, go wherever people will have you. And I would say to that, you know, if you can't get in front of a large audience, to Ellen's point, go to a small audience, but also really focus on being useful to the people you're talking to when you're talking to, more than the size of the audience. Because this is sort of like anything else, like word of mouth will help you as much as anything. And if you provide useful information to one case manager, that case manager will tell other people. And same with providers, et cetera. And so some of this is like, yeah, it's not a either or, it's a yes and belt and suspenders. Let's put it all out there and try all methods to see what's going to work with your community, your group, your providers in your setting. And the truth of the matter is, like, you might end up getting more relationship building and more use out of one really great interaction with a case manager who goes on to tell the story of her great experience than you might from a training that was in front of 50 people. And so I would say really focus on making sure you're meeting the needs of the person in the room, and like thinking about how do I make this person in love with this work so that they kind of go forth. And to that point, I think this is another reason in terms of like asking the question, picking training topics that it might not be number 1 on your list as an attorney, but it might be number 1 on the list of like the people who are making referrals. And this idea of, you know, we've seen this over and over and over again in the MLP world. If you have a provider or a case manager who's been stuck on a question, and you are able to answer that question and or help that patient, they'll come back for all the other information you want to share with them in the future. Solve their problem, and you have an ally for life in this work. And so that's actually sort of a re-engineering of thinking about it. Go out into the health center and solve the problems or answer the questions that are sticky, that you can answer. And when that happens, you'll find you have an audience for these other things. And so really thinking about how to do that, how to sort of build goodwill and relationship building. And the last thing I'll say to that point is, if you come at a group of, it doesn't matter which side this is going in bidirectional training, if you come at a new group of people and the posture is sort of, here's this new thing you need to know and this new thing you need to learn on top of the other 25 things you needed to learn and do today, that's a burden, right? That's just psychologically feels like a burden. If you come at it with, you currently have 25 things on your plate, let me take one of those off for you by answering that question or having you give me a referral. It's the same, you're sharing the same information, you're doing the same thing, but the framework of it is, instead of, let me tell you one other thing you have to do, let me tell you one thing I can do for you to take off something you're already thinking about. And that psychological switch is so like crucial in getting people to lean in and say, yes, I have time for this. So I just want to throw that out there as well. And then I'll kick it back to Ellen, because I know we have another question in the chat.
Great. Thanks so much, Kate. And yes, we have another question in the chat. And just so folks know, like, we're here to just keep fielding questions, however long you can be with us. I think we're slated for another 30 minutes. And, you know, if that's what it takes, great. But also just letting folks know that we're eager to respond to your question. So here's a question from Haley, which is, how do you build trust within the healthcare side of an MLP when physicians, medical social workers, et cetera, become frustrated with attorney-client privilege and finding that cases are being denied due to capacity, insufficient experience, lack of legal concern, et cetera, but lacking the context, right? Awesome question. Again, foundational question, right? How do you build that trust? So I'm going to take a stab at it and really want to hear from Noelle and Kate, their particular insights. So a couple of things, you know, the trust building is the relationship building, right? So that comes as it rides alongside the training. It's not, the training is a mechanism for building that trust, but there are other ways to build the trust. And part of that is, to Kate's point, is asking questions about what they need, right? And so you can be in an active MLP for multiple years, and the folks that have been referring cases to you still don't really understand all of the facets of MLP, right? They don't understand how some of the facets of it work, right? And that's okay, right? But what you're trying to do is to build that trust in all the different ways you can build that, not just around individual cases, right? But helping them understand, you know, what you can do and how ways that you can help, rather than, you know, and I'll just say my personal experience with this, which is that, you know, I think that in the legal world, in the legal aid world in particular, and I was guilty of this early on in my career until I got feedback from my healthcare providers. I used to lead with, I can't take these cases, and give them a whole list of things that I couldn't do. I can't do immigration, and I can't do family law, and I can't do this, and I can't do that, and they have to be under 150% of the poverty level. And that's how I would kick off my trainings. It's all of the things that I could not do, right? And that messaging extended for me to when I would respond to an inquiry. And I remember this one really well, when a physician called and he said, you know, I have a patient who has this problem, and can you help? And I listened to some of the facts and I said, no, I can't do an intake on that. And the physician got really frustrated, and understandably. And when I reflected on it, I thought, you know, he doesn't even know what an intake is. But I just told him that he can't have one. And what I should have done is say, you know what, actually, we don't handle those kinds of cases, but I'm going to call, you know, Jane Smith at this other agency and see if they would be able to handle a case like that. And they handle this and that, right? So I acted more as like a primary care lawyer than a, you know, thumbs up, thumbs down on the intake line person, right? And that messaging, just changing how I delivered information on the healthcare side. He didn't care whether he got an intake ultimately. He knew that the resources were scarce. He just wanted to be able to say to his patient, like, I'm getting some more information for you, and I'm going to try and help you. And so, again, being very attentive to your messaging with individual physicians and social workers, and trying to think about what you can accomplish together, right? Because one of the biggest challenges in medical legal partnership work is that you have now left the legal aid office, you've left the intake line that protects you from, you know, the tsunami of calls that are coming into your office. And you are the intake line for all intents and purposes, right? And that's what's really, I think, scary and intimidating for lawyers inside of healthcare. And so thinking about that role is to not be afraid of it, but rather understand kind of what your messaging is and how to approach your work, given that you have this opportunity to connect with people who aren't thinking about the intake line and access. So I'm going on. I know Kate has insights there too. I took a little moment there just because I know we've got a lot of time on Q&A. So Kate?
Yeah, I think it's just quickly building on, what Ellen was saying about, there are times when you have to say no, but it shouldn't be the only thing people are hearing. And I think this goes to a fundamental, I think one of the things that we have come up across in the MLP world over and over again is like, are we a referral service or are we an integrated partnership? And if we are, and we always say we're an integrated partnership, which means we're so much more than just the referral. And if we're just the referral, then yeah, it gets into yes and no. Like we can take this and we can't take that. And it's a huge part of the work, right? But we are also this knowledge exchange. We are also building capacity in each other to better understand these, to better understand when a case manager has another resource, or when a case manager can do something else that they didn't know they could do before because they have guidance from a lawyer. And so it's sort of like this idea that, training is more than these 90-minute sessions. It's all these little interactions. Medical legal partnership is more than the referrals. It is the referrals. But if you are having other interactions with healthcare staff, and you're having these moments of sharing information and building capacity and going back and sharing wins, like that's another thing that I think we just don't do enough of, is like, we need a feedback loop that isn't just this like one individual case, here's what happened, but going back to a training and say, hey, guess what we did this month? And I actually want to invite this nurse to like talk about it because she was instrumental, and I want the group to hear her experience with this, and like bringing the positivity front to mind, because this work is hard. Like it's the work lawyers do is hard, the work healthcare staff do is hard, and the work you do together is hard. And like people need to hear that things are working. They need things to celebrate, even though we have to also acknowledge the things that don't work, right? Just as much, and rebuild our processes. And there are going to be no's on the referrals. And so I would just encourage alongside of this to spend as much time doing the other activities as possible, and to find ways whenever you're interacting with people, especially at trainings or wherever else, to call out those successes and the shared positivity that exists between you. And I don't know if Noelle, you have anything that you'd like to add to this question.
This I do actually, and I just want to piggyback on something you just said, Kate. And this is a great question. I was writing down, I should mention this, and this. But just to build on what Kate just said about celebrating successes and that feedback loop, that's one of the things that we are doing, because what happens sometimes is a social worker or a provider or someone will submit a referral, it goes through our process, and then they never hear back, but they work so much with that patient. And, to be told, well, that's attorney-client privilege, I can't share with you if we took that case or what we did with that case. That doesn't sit well, right? Because they are the advocate for that family or that individual. And so there's certainly, this is kind of the two different worlds, right? So this is where you have to acknowledge attorney-client privilege, but, it's really important to be able to say, you know what, I totally understand why you want, you would want to know that. And if that individual gives us permission, we can definitely talk with you about that. But just kind of explaining that, because the medical providers understand HIPAA, but they don't necessarily know the whole attorney-client privilege. So again, it's kind of marrying these two worlds. One of the things that we do is we do a semi-annual report, and that's really it's of our data, it's of our the types of cases, the demographics, the reach, like which counties our individuals that we serve come from. It's mission moments, it's systemic advocacy wins. And not only do we share that with our executive leadership team, but it's also getting that back to our key referral folks. And that tends to be social work, so it's like we're trying to kind of even out we send these to you, but we don't hear back what happens with these. But it's like, but we can share this aggregated information with you. These are some of the things that we've been able to accomplish in the last 6 months. So it demystifies it, and it's like that, feedback loop. I think that's really important. Another couple of things I wanted to just mention. I think being clear on your model up front can really help to diffuse some of that frustration. So like we try and be very clear about, we have a pyramid, and the bottom is of our pyramid where we spend the bulk of our time is on consultations and provider training. And then we do legal representation, and then the top of the pyramid is systemic advocacy. So if you're clear from the get-go, I think you're setting yourself up for more success and more collaboration, because they recognize that you have limited resources, but the consultation and the education can go really far. So it makes it more palatable when, as Ellen was sharing, when you have to say no, it's more palatable if they know, well, you're definitely going to get some resources. You just might not get direct legal representation for the family or individual that you're working with. So I think being really clear on your model, always sharing resources. Two more things I just wanted to mention super quickly are we have, and I don't know what it's called in each state, but Legal Services Corporations has like a legal repository in Washington State. It's called Washington Law Help, and it has so much information on all these different issues. So even when we hit the situation that Ellen was talking about, where our MLP isn't going to do maybe a family divorce situation that's outside of our scope, so to speak, we can refer people there and say, this great repository has information on things we help with and things we don't, because we use the iHelp mnemonic, the income, housing, education, legal status, and personal and family stability for kind of our scope of our MLP. But we can put that out there and we can say, here is this great repository that has information on all sorts of issues, including things that don't fall into our bailiwick. And it's in all these different languages, and there's staff who keep this current. So I think that's another thing. So it's like, well, we can't do this, but we can do this for you. So people never walk away empty-handed. And the last thing I would just mention on that is, I am a really big believer in the value of pausing periodically and doing some type of strategic conversation or a strategic plan where you loop back with your key stakeholders and say, this is our model, but over the last however long, there's been a lot of turnover, there's been a lot of change in the world, and does this model still fit? And if it fits, great. But if we have to make some adjustments here or there, you're on the front lines. Give us that information so we can work with you to adjust things. So I think that kind of being attentive to the relationship, I think, will take you far.
Great. Thank you so much, both of you. We're going to start to move forward with wrapping up today because I'm not seeing any more questions in the Q&A. But it's been really a great opportunity to cover a lot of territory because of the great questions that we have gotten. And now I see Margaret Holding raising her hand. Margaret, do you want to unmute and hop in or post in the chat before we wrap? Now's your shot, or did you do it by accident like Nola? Hello?
I think we can move to the next slide, and if there was a question, we can maybe throw it in the chat and we can circle back to it.
Hey, I'm sorry. My computer is about to die on me. That's why it's taking so long. And yes, I've been writing this question for like 22 minutes. So anyway, my question, addressing what Noelle said, if like a social worker has to have a patient sign a release for her or him to discuss with you, could it be bi-directional? So that then you could then discuss back with him or her about the case.
Great. So thank you for that. I'm going to use that as an opportunity to just talk big picture about information sharing, right? Because those rules differ from, state to state. profession to profession, right? And I'll just say globally that we have done so much work in the field and in the MLP field to figure out how to share information with each other, right? So we don't really, I think, have excuses now to not have a feedback loop of some sort. How formal it is, whether it's, you know, on your Epic medical chart and your legal server, legal database, whether it's, you know, pen and paper, whatever it is, we have ways of sharing information. And so really encourage the lawyers and the healthcare team members to get together and figure out what kind of information you want and what it's going to take to share it. Because to Kate's point, the feedback loop is everything. It's what allows you to understand what's happening on both sides of the equation. And I think that these two professions can figure it out. So, so that would be my reminder, is that I think we have strategies, we have case studies, we have tools at the National Center that tell us how to share information and what we need to share. It's not complicated in terms of the amount of information. You actually don't need that much. They're not looking for much, as Noelle referenced, right? Did you catch the case? Were you able to help? What were you able to do? And does the patient allow us to share information with each other? Most, I would say, most patients want us to share information. And if they don't, they'll let us know that, right? And we're used to signing releases on the legal side. Certainly on the healthcare side, they're thinking about that. And there's a sweet spot there in the Venn diagram where we can share some minimal information so we can make sure that we're meeting the needs of the referred patient. So that would be my 2 cents commenting there. And then I think we're going to be moving to wrap. Is that right?
Yep, I think that's right,
Okay.
Ellen.
Take it away, Kate.
Awesome. And again, thank you all so much, not only for your time, but for your questions. Oh, can we go back a slide, actually? I just want to walk through these quickly before I turn it back over to Danielle to do some housekeeping wrap up. And also just want to encourage people while I'm walking through some sort of wrap up tactical tips. If there's something that you are doing in your MLP with training that you find really successful, or a promising practice of your own, I think this is the perfect time to share it in the chat. Would love to hear what is working for other people, and be able to have all the participants sort of see that. So please throw that in the chat as we're wrapping up. So just some closing thoughts, some tactical tips. Some of these we've already talked about, but I just kind of wanted to end on some of these. So make sure that you're seeking input and you're co-creating. So it's been a common theme this whole time. So both on topics, but also what's going into these, right? Don't create trainings in a vacuum. Build them together, decide on topics together, decide on formats and settings together. Like when we really are talking about this idea that MLP is about jointly working together on stuff, that's what it should be, like joint in the creation, not just, how to get from service, a patient from A to B. Number 2, lead with that story, that question, or that bold fact. Really remember that when we're engaging in training, we are connecting this topic to somebody else's why or somebody else's need. And so whatever you can do to sort of get in that headspace, to understand their entry point to the topic, and then start first with that engagement piece before you ever to get to how or what. So start with why. Default to less is more. So when we're thinking about 15-minute trainings, if people want more information, they'll ask for more information, right? Like for the most part, that's true. So you're better off. I often say it like this: if you go into a small window of time and you say, I'm going to tell people 15 things, people are going to remember 2 to 3. And they're going to remember whatever 2 to 3 come to mind for them based on however their brain processed that sort of thing. If you go in and say, there's 2 things you need to know in order to be able to make a referral for a reasonable accommodation, they'll remember the 2 things. So it's called, like, I think of it as information hierarchy. If you throw a whole bunch of information at people and every word on the slide is the same size, font, And like, you are just giving them everything, but you aren't helping guide them to what's most important and then what's underneath that. If there's no information hierarchy, it's the Wild West about what people will understand in terms of like what they'll remember coming out of that training. So, make it easier for people by like doing less is more and sticking to those things that are really, really important. And then the last thing, like this came up so much in our warm-up activity about like we work in different systems and we have different languages and oh my gosh, the acronyms, like acronyms for days. And so some of this work we do in MLP is like learning each other's systems and language and making time and space for that. Like that is some of the most important homework we'll ever do in the MLP world. And so not just learning, but like practice, like have conversations where you actually practice analogizing together. What is legal services equivalent to in the health center? If I were going to give this training to health center staff, what's the metaphor that I would use? And so when I was talking earlier about how if you want to engage someone in a topic, it's stories, bold facts, and questions. If you want somebody to understand something that's new to them and you want to increase processing, you want to increase ability to understand, it's metaphors, it's cultural cues, and it's things like social math, right? So it's putting what you do in their language. It's using their verbiage, it's using metaphors they're familiar with. Oftentimes when I'm talking about a legal issue with health center staff or a hospital staff, I'll differentiate. I was like, well, if this happens, it's an emergency room. They have to go to the equivalent of the legal emergency room. If this is happening, we can go to primary care, right? Like this is a time we need to like have kind of a conversation, but no, this is emergency room. They needed help yesterday. And so just those little things of like putting it in language that is just more accessible, it does some of your work for you. So take some time when you get a chance, even if it's just with one other person, to practice analogizing. And I think that's where we are, wrapping our presentation today. I am going to hand it back over to Danielle because I know she has a few wrap-up thoughts from the National Center, but I just want to say so much on behalf of Noelle and Ellen and myself. Thank you so much for coming, for your thoughtful questions, and to just wish you all the luck in your trainings and to tell you to experiment and see what works. So with that, I'll hand it back over to Danielle.
Thank you, Kate. And to reiterate that, I want to thank all three of you, Lawton, Kate Marple, Noelle Rees, for sharing your experiences with us. It has been a delight to learn from you all. And I want to thank the audience as well for joining us today. We really look forward to seeing you in the two final sessions of this series, which will occur before the end of this year. So one will be in November and another one in December. So we encourage you to subscribe to our newsletter. And I see that Catherine has shared the link to that in the chat so that you don't miss any upcoming learning opportunities. You can see on the screen here that we have two that are coming up really soon. One is No Wrong Door for Veterans, which is scheduled for November 9th. And the other one is going to be about how MLPs can address the legal needs among racial and ethnic minorities living with HIV, which is scheduled for December 7th. And you can find more information about these webinars on our website. And Catherine has shared the link to that as well, so you can easily find it. Also, please take 2 to 3 minutes to respond to the survey that Catherine has shared with you in the chat. Your feedback really matters to us. It helps us improve and shape future events. So please respond to that right after this webinar. Again, thank you to our panelists as well as everyone who joined today for such an informative session. And I'm happy to give back 5 minutes of your time. Thank you, everyone. Goodbye.
Bye, everybody. Thank you.
Thank you.